this whole chapter is on the heart. We're going to talk about the anatomy of the heart, then blood flow through the heart conditions, and then we'll be done. So, you have two loops in your heart, your whole blood circulation. You have a pulmonary circuit. Pulmonary circuit runs to your lungs, and then you have the systemic circuit. The systemic circuit runs through the rest of your body. So if it's pulmonary anything, it's pumping it to your lungs. If it's systemic, it's pumping it the rest of your body. When oxygen comes in to your lungs, it meets the blood in your lungs, where the oxygen goes from the air to your blood, and then your blood carries that oxygen to your tissue and drops that oxygen off, picks up the carbon dioxide. Carbon dioxide is brought back through the blood, then back to your lungs. The lungs take the carbon dioxide, exhale it, and then you get more oxygen. So it's talking about the exchange of oxygen and carbon dioxide throughout your body. So systemic is going through all your tissues. Pulmonary is just your lungs, where we drop off and pick up oxygen and carbon dioxide. Right atrium and left atrium, so we're going to talk about anatomy, and it kind of goes through anatomy for the majority of this chapter. When you look at a heart, and I don't have a model to hold in my hand, so I'm going to spend a lot of time on the picture. The atria are your superior chambers. The right is on the right, the left is on the left, unless you're looking at your patient, and don't forget that it's the cross, the opposite, okay? So when you're looking at your patient, it's their left and their right. You're not looking at the right and left for them. The atria are what we call collecting chambers, so they're going to collect blood. The right atria is going to bring blood back from your body. So it will have three sources of blood dumping into it: the superior vena cava, inferior vena cava, and the coronary sinus. The left atria is going to receive blood back from your lungs, so that it can get ready to prep it to distribute it through the rest of the body. The ventricles, they have much more muscle in comparison to the atria, because the atria are collecting, they're just bringing things in, collecting it, but the ventricles are going to propel that blood to a specific destination. The right ventricle is going to propel the blood to the lungs, and the left ventricle has to shoot that blood up and out to the rest of your body. When you compare the two side by side and you do your heart dissection, you'll see this, that the right ventricle, the layer of muscle, although it's there, it's thinner, because it's only propelling blood to a short distance, pretty localized. Whereas the left ventricle has a really thick muscle, because it has to shoot that blood up through the aorta into the rest of the body. So, and that also impacts the shape of the heart and the direction in which it points, which we'll discuss. I love this diagram, but I'm a memorizer, so I remember right lungs, left body. Right lungs, left body. Right lungs, left body. Because you go from the right atria to the right ventricle, and then the blood goes, so right, then it goes to the lungs, then it comes back to the left atria, left ventricle, and then it's shot out to the body. So right lungs, left body. Right lungs, left body. That's how I remember the blood flow, because you have to know the order in which blood flows through the heart. Right lungs, left body. Now, you can see here is showing systemic. Remember, systemic is to the rest of your body. So the red is showing oxygen rich, and the blue is showing oxygen poor. So the oxygen rich blood is coming in, it's dropping off that oxygen, and it's picking up that carbon dioxide. Is the blood itself actually blue? No, it's just oxygen poor. Then it carries that carbon dioxide and low oxygenated blood back to the heart, where it goes right, then it goes to the lungs, and then it comes back oxygenated, left body. Now, in 01, I mentioned, when we see red, we say it's oxygen rich. When you see blue, you say it's oxygen poor. Normally, people memorize arteries go away from the heart and veins come towards the heart, which is true as far as terms are concerned. But it is incorrect to say that arteries are always red and veins are always blue. Okay? Because this is one of the two exceptions. Heart, and the second exception will be when we're pregnant. The umbilical cord is also the opposite. So if it's labeled an artery That means that it's taking blood away from the heart. That's the definition of an artery. But it doesn't mean that it has to be oxygen rich. It just means that it has to go away. So here is the first time you see an artery that is blue and not red. Because when it goes from the right atria to the right ventricle, it will be carried away from the heart to the lungs. This is called the pulmonary arteries. Pulmonary trunk, pulmonary artery. Away, then it gets oxygenated and it comes back through a vein. Vein just means it's coming back towards the heart, and in this case it's just oxygen rich because it went to the lungs. So normally in our tissues, when we say arteries and veins, arteries are red and they go away, veins are blue and they come back. Here's an exception. Arteries just have to go away by definition, and veins just have to come back. They don't have to be red or blue. As far as the location of the heart, it's in the mediastinal cavity, so we've discussed that. Superior mediastinal. It mentions the location. The base of the heart is actually the top of the heart. The apex is the bottom. Your heart actually points a little bit to the left. The apex is a little off to the left, and the base kind of comes over to the right. But that's because the muscle in the left ventricle is so much bigger, it's kind of pulled it that way. So the heart should kind of point to the left. And that also lets you know if you're looking at the front or the back of the heart. Because sometimes you pick up the heart and you're like, ooh, this is the front and the back. But you look for the apex. The apex should be pointing to the left if you're looking at it anteriorly. Here's the positioning of the heart. You can see that it's clearly protected by the thoracic cage. It's going to be kept in the pericardial cavity, which we will get to shortly. And the base of the heart is here, and the apex there. This is the only non-symmetrical organ in your body. Everything else should be pretty symmetrical, textbook-wise. So, you have the two kidneys, everything else you divide in half. If you even just cutting down your thoracic cage, you have the same and same. But your heart is asymmetrical, so when you cut down the middle of it, it's not perfect on both sides. This is a transverse cut, so you're cutting across, and I can tell roughly where this is. I know this is the back of that person. I'm navigating it because this is their vertebral column. Okay, I can see the two lungs here, and here are the chambers of the heart, the atria and ventricle. This is showing you another section, of course, but it's showing you within the pericardial cavity, which we've discussed. Remember that serous membrane where you have the visceral pericardium, parietal pericardium, and the pericardial fluid? That's what this is depicting, and we're actually going to come up to that in just a moment. Right here. Okay, so the heart itself is protected by a fibrous layer called the pericardium. Pericardium keeps the heart protected from all the surrounding structures, like your lungs, your vessels, and so on. So it kind of separates it. There are two layers. The visceral layer. Viscera is organs, so that means that that's the layer that's touching it. So this is the very surface of the heart itself. Also referred to as the epicardium because it's the outside surface of the heart. So the visceral pericardium and the epicardium are the exact same thing. It's just, am I talking about it being, say that one more time? Right, it's not either side of it. They're literally the same thing. But am I talking about the outer lining of the heart or the first layer of the pericardium? They're the exact same thing. Okay, so epicardium and visceral pericardium are the exact same thing. Parietal pericardium is the one that's separated from it. Remember I had mentioned it kind of being like a Ziploc bag, kind of like a sac. In between the two is a fluid, and we call that fluid pericardial fluid. We call these specific names because it gives us directions on what we're talking about. The purpose of that fluid, again, is to decrease any type of friction that may result as those two are rubbing past each other, and that heart is contracting. Okay, so here's an up-close layer, and it's showing you where I've cut it out here. Here's the inside of the heart. The heart has a whole bunch of muscle. Myo tells me muscle, so it's called the myocardium. This is the muscle part of the heart. And then here is the epicardium or visceral pericardium. Same exact thing. Then it loops around here. I have the parietal pericardium, and then I have the pericardial fluid. On top of that, parietal pericardium, you have a layer of connective tissue that's helping to hold it in place, so the fibrous layer that it references. Okay? What does itis mean again? Inflammation of, so pericarditis is pericardium. Okay, so inflammation of the pericardium. Ultimately, this could be a couple of things. It could be an infection. It could be that overall it's just rubbing. It increases the friction, so it increases the blood flow, swelling, all of that is increased. Because of that, we start to hear a sound when you listen through the stethoscope. You don't hear it like you hear it, oh, I have pericarditis right now. You can't hear it yourself. You have to have a stethoscope to hear it, but you can hear kind of like this rubbiness on it. There's a lot of different things that could cause this. Okay, mainly it's going to be infection, but here it talks about cardiac tamponade. What happens if there's too much fluid in that pericardial area? What's the fluid going to do to the heart? It's going to squeeze it. So if I have my heart here, and I have my pericardium surrounding it, like we've discussed as far as the anatomy goes, and this fills with fluid, so normally my heart does like this, but as it fills with fluid, it puts pressure on it, so it's trying to, but it can't. All right, and that's what it's mentioning here. If I have that situation, I need to go in and drain that fluid so that there's not an issue with how the rate at which my heart beats. Yes, ma'am.
I was going to ask you, are the symptoms of that like fatigue?
Yes, that's it. You know what? Let me go ahead and say this. Anytime that there's a heart problem, anytime that there's a lot of problems, one of the main symptoms is fatigue. So if a patient comes in and they're like, I don't know, doc, I've just been tired. They could, yes, that could be anything. And so you say, all right, you ask some questions, what have you been doing? Anything changed? You ask your normal questions, but you're always going to do a blood draw because you're trying to figure out what is it that's causing that fatigue. But yes, ma'am, and if anything's wrong with the heart, oxygen levels are going to be low. If oxygen levels are low, that's going to lead to fatigue. So,
I have a friend who always falls asleep, and I think that's what he has because he already has all these
other
health
issues.
Yeah.
Yes. I always fall asleep, but that's because I'm tired. So I wonder if people think that there's something wrong with me. But I hope that your friend's healthy. All right, 3 layers of the heart. Epi tells us it's on the outside. Myo tells us it's muscle. And endo tells us it's on the inside. So if you can figure out those roots and it says cardium, you know that I'm talking about the heart. Okay? That would be the goal there. The epicardium, once again, is the exact same thing as the visceral pericardium. They are one and the same. It just depends on how you're referencing it. Myocardia is the muscle of the heart. Your heart has to have a whole lot of muscle, and we're going to talk about the nervous system as well, but because it's constantly contracting in order to propel blood throughout your body. And it contracts asynchronously, so it goes, and we're going to end up calling those sounds lub-dub, 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 because you don't want them both contracting at the same time, because if that were the case, the blood that was here couldn't get, there wouldn't be sufficient blood circulation, and that would be an arrhythmia. And we'll talk about that, an irregular heartbeat. But you should have cardiomyocytes, which are the type of cells that we find in the heart, muscle cells. And it kind of has this really cool pattern. I'm going to show you the pattern real quick, and I'll go back. But this is the situation we have with the myocardium, the way that the muscle is designed, and it kind of laces kind of a figure 8. But the atria contract at the same time, and while these are contracting, the ventricles relax. And then when the ventricles contract, they relax. So they should be taking turns. And it's pretty intricately designed. So it works out really well. It looks cool. Let me make sure I've said everything. Wait. I went too far. No, I didn't. Okay. Here's where I was. Myocardium. And that's the muscle. The endocardium is the inside of the heart. The inside of the heart is continuous with the inside of the blood vessels. So the inside of the blood vessels, remember, was lined with an endothelial tissue, We know it's epithelial because it's thelial. Endo tells us it's on the inside, so the endothelium is continuous with the inside of the heart. So the endocardium is lined with endothelial tissue, and it mentions that. So it's continuous with the blood vessels. We have this exact same line up here we saw just a moment ago. Endo, myo, epi. This is not epi, sorry. When I did this and I came back, it pointed there. So the epicardium is just the outside layer of the heart. That's the pericardial cavity, the space in between it. Myocardium. The chambers of the heart. You have 2 atria, 2 ventricles, so you should have 4 chambers. In between the 2 atria, there's an interatrial septum. Guess what a septum is? It's just a wall. It's a division, so that we can keep what's in the right separate from what's in the left. Then you also have a right and left ventricle, and then there's an interventricular septum. So just, again, it's telling you specifically where that septum is located. Okay, so the fossa ovialis, we're going to talk about one other, the ductus arteriosus, one other remnant. But when you are in your mother, developing embryonically, you don't breathe for you. Your lungs don't work. In fact, your lungs are the very last organ to mature. And they actually determine when you're going to be born, because when your lungs are mature, they release surfactant, which stimulates oxytocin and so on. Anyways, because you don't have to breathe in utero, because if you did, you would drown, because it would just be fluid, your lungs are completely collapsed in utero. And your pulmonary circuit, which takes blood to your lungs, doesn't operate because there's no oxygen in your lungs. Does that make sense? So there's a hole in your heart that bypasses that. But as soon as you're born, when you take that first breath and they suction all that fluid out and they try to get the baby to cry, that immediately slaps that hole shut and it sends blood to the lungs and gets that baby to breathe the way that it's supposed to. It kind of is like an airbag, but the baby has to take in oxygen in order for that to happen, to close. So you do have this small little scar, little hole. It's called the fossa ovialis. It's just showing us that that's where that hole once was. So, because we bypass that. And when babies are born and they're like, oh my gosh, my baby has a hole in their heart, that's actually not very uncommon. It just means that didn't close, and we're going to talk about that towards the end. So if that's the case, the baby's tired because oxygen levels are low and it's a heart condition, but you have an infant, newborn, so they're normally tired anyway. We wait a little bit, they go in and they close that heart. They close that hole, not the heart. Okay, sorry. So here's a good looking heart. Here is the remnant of that opening. So that we have an opening here, and we'll also have one here, because this would take blood to the lungs, right? But because the lungs aren't functioning, we don't need it to go to the lungs. So there'll be a hole here. So there's 2 places that there could potentially be a hole, there and here, after that baby's born. But I have the 2 atria, I have the 2 ventricles. This is a great picture. You can see the thickness, the muscle. You also see here these white structures. Those white structures are called chordae tendineae. They're responsible for holding the flaps of your heart valves in place. They're also referenced as your heartstrings. So when they're like, oh, you're pulling on my heartstrings, that's a literal term for these right here. And that means that it's causing issues with blood flow in my heart, which means it hurts my heart. So it all has like a literal terminology, yes. You do have 4 valves that you and I are going to study. We have this one, and then these 2. So you have 2 semilunar valves and 2 atrioventricular valves, not interventricular, sorry. So I have an atria. And again, this is the arteries. These are pulmonary arteries, so they're going to take that to the lungs. This is the aorta. This will take the oxygenated blood to the body. What else? The vena cava, superior and inferior vena cava, will dump right into the right atria. We'll talk about that. What else? Oh, we're about to talk about the inside sometime in a minute. And it's going to say trabeculae. When we were in 01, we talked about trabeculae kind of being in spongy bone, like that, those weaving canals. That's the same setup we have right here on the inside lining of the heart. It's going to talk about its trabecular surface. So that's that there. Let me see if there's anything else that kind of jumps out where I'm like, oh, we're about to talk about that. Not at this moment, but I'm sure something will here in a moment. Okay, sulcus. Anytime we heard the term sulcus, that means like a groove. Okay? So the last time we heard it, we were talking about the anatomy of the brain. So coronary sulcus. Coronary tells us it's where? On the heart. And this is just a deep groove on the heart. We have an anterior interventricular sulcus. What does that tell you? It's on the front, in between the two ventricles, and it's a deep groove. Okay, then a posterior interventricular, same thing. So once you learn these terms, like when people say things, you're like, okay, this is what that means, and this is what this can lead to, and so on. The term auricle. So you have your two atria, but your atria kind of have this, you know how sometimes you eat normal amounts, but when it's the holidays, you eat a lot more, but your stomach will stretch to accommodate that, right? And if it doesn't, you throw up. Sometimes even after you've stretched it, you then throw up because you've overstretched it. But your stomach itself has the ability to stretch to accommodate more food than you normally eat. So do your auricles. Your auricles are that stretch function for your atria. So they allow your atria just to stretch just a little bit more, especially if you do things like work out a lot, your blood flow changes. Yeah, so in the event that you need a more blood, it can take in more and it can kind of stretch, and you're not specifically limited to that anatomical structure. The right atria is on the right side. It receives blood from all of your body. Your left atria receives blood just from your lungs. It mentions here, it's talking about the auricles that allow for it to expand. That's what the slide is specifically addressing. When we talk about the right atria receives blood from the superior vena cava, inferior vena cava, and the coronary sinus. The left atria receives blood from the pulmonary veins. Oh yeah, it says everything. Coming back. So pulmonary veins. The right ventricle receives blood from the right atria. The left ventricle receives blood from the left atria. The right ventricle is going to send blood to the lungs. The left ventricle is going to send blood to the body. Right, lungs, left, body. Right, lungs, left, body. Trabeculate, I mentioned that. That's those ridges inside the wall. So they're kind of like that tunneling type thing. And that chordae tendineae is what anchors the cusps for the valves. Okay, so the anchoring surfaces. The ventricles are thicker than the atria because they have to pump a further distance. The atria are just dumping down, so the muscles at the top of the heart are thinner than the muscles at the bottom of the heart where the ventricles are. The right ventricle pumps to the lungs, the pulmonary trunk. Left ventricle pumps to the aorta, which is the rest of your body. And your aorta, it's not going to show you that right this moment. It'll show it to us on the next time we're together. But the aorta starts at the heart, and it curves up, and then it kind of goes down. So the aorta is not just in one little location. You'll hear them say like your thoracic aorta, okay, abdominal aorta. That's telling you what part it's referencing. So your aorta is not just one little extends, okay. Structures here. So see how this kind of looks it just kind of looks weird, like a gummy type thing. That's the auricles on top of the atria. Okay, so they have the right, the left. Then here's the right side. The left is where the apex is. Again, you can use the apex to distinguish where it is located. Interventricular sulcus. Okay, so it's in between the ventricles, and it's a groove, and here it's accommodating blood vessels. Coronary sulcus, so we're getting some vessels in there. This is anterior, of course. I don't think I see anything else there. Here's a cadaver heart. This is what it's yours is not going to be this pink. Yours is going to be gray, the one you get, because it's going to have none blood at all. So this is just out of somebody fresh. You can tell by the coloration, but I would find the apex to determine where the front of that heart was. Okay. Here it is cut open. You can see the trabeculae are quite apparent there. Here you also have those heartstrings, that chordae tendineae, holding onto those valves. Okay, so let's talk about the valves. So you have the 4 chambers so far. You have the right atria, the right ventricle, the left atria, the left ventricle. There is a valve between the atria and the ventricle on both sides. We call it an atrioventricular valve. Does that make sense? Because it's between the atria and the ventricles. So it would be easy if we just left it like that. If we said the right atrioventricular and the left atrioventricular, that would be nice and straightforward. But it's not like that. The right atrioventricular valve, also called the right AV valve, can also be referenced as the tricuspid. The tricuspid because the valve itself has 3 cusps to it, like 3 little lips to it. So you might hear it called the right AV valve or the tricuspid. Those are used interchangeably and they're the exact same thing. Wait till we get to the left side. Because the left is called the left AV valve. The bicuspid, and why the bicuspid? It's just got 2 cusps. It's also called the mitral valve. So it's got 3 names, and the right has 2. So right AV and tricuspid, left AV, bicuspid, or mitral valve. 4 of those. When your atria contract, those valves open, allowing blood to go down. And as soon as the contraction's over, those valves slap shut so blood doesn't go backwards. Okay, so they're one-way valves to prevent the backflow of blood. And those valves are held in place by the chordae tendineae, which are those heartstrings I had pointed out previously. I'm listening.
What do you think if the valves don't close properly?
Okay, so we're going to talk about stenosis or over leaky valves. That's going to be a homeostatic imbalances. Yes. So here is showing you where those valves are located. So here are my atria, and you have those valves. It's showing you here that the ventricles are full. Blood comes into the atria. When the atria contract, those valves open so that the ventricles can fill. When the ventricles are full, the valves slap shut. We don't want blood going backwards. We want it to be a one-way flow. Okay? And I'm going to say this one time, and I'll say it again in a little bit, because there's another diagram that a lot of students become confused on. In these diagrams, it shows that once that blood is that there's no blood anywhere else. These are for teaching purposes. Like, the blood is constantly cycling through. So I don't want you to be like, oh my gosh, your heart's empty at this point. No, it can't be. It can't afford to be empty at any point. But these are to show you how that flow goes and what everything kind of looks like. Okay, so those are the first 2 valves. We have 2 more valves. So we have the AV valves, atrioventricular valves. Now we also have what we call the semilunar valves. Semilunar valves are the ones that take it from the ventricle to its destination, whether it's the aorta or the pulmonary trunk. So you have the aortic semilunar valve or the pulmonary semilunar valve. And thank goodness those are the only names for those. Okay, so I feel like that's pretty straightforward, as long as you understand that semilunar means it's going from the ventricle to its destination. All right. Again, they prevent backflow. So here, my right ventricle will pump up to my pulmonary trunk. This is my pulmonary semilunar valve. And once that blood gets up there, that valve will slap shut so that blood does not come back. My left ventricle is going to pump to my aorta, and you can't see the aortic semilunar valve, but it's there. And then once the blood gets up there, it slaps shut so it doesn't come back down to the ventricle. So if I were to give just a little bit more detail at this point, I would say from your right atria, blood flows through your tricuspid or right AV valve to your right ventricle. From your right ventricle, it will travel through your pulmonary semilunar valve to your lungs, then come back to your left atria, go through your left AV, bicuspid or mitral valve to your left ventricle, then from your left ventricle through your aortic semilunar valve to the rest of the body. Okay? And that's the detail. We're going to add a couple more, but that's the detail that you have to be able to know it. But right lungs, left body. Right lungs, left body. Here is the diagram that shows all 4 valves. And if I was just trying to navigate myself, I would count cusps. So I know I can see here that there's 2, here there's 3, this is my tri, this is my bicuspid. So it tells me what side of the heart I'm dealing with. You can see that the semilunar valves are identical in their anatomy, so it would be difficult to distinguish if I didn't know which vessel was which one, right? I would use the aortic valves, or atrioventricular valves. So you can see, this is what your heart's going to look like. That's what it's going to look like. It's not. Wouldn't it be cool if it looked like this? You're like, oh, I can see it. No. Yours is, dead, and it's been there for like 7 or 8 months, waiting for you to show up. Yay! This is a good picture. This is a super small camera that they've put inside a heart to kind of look at the anatomy, and you can see the chordae tendineae, the heartstrings holding down those cusps. It looks cool. I think it looks cool. Okay? Your heart may look a little bit like this if you cut it right. A lot of you are going to cut it and be like, my heart only has 2 chambers. No, or your person or your lamb would be dead. I think we're doing sheep heart. So, all right, homeostatic imbalances. When we're looking at the valves, you can have incompetent valves, which means that they're too flappy, or you can have stenotic valves, which means that they're too stiff. If your valves are incompetent, that means that instead of keeping blood going in one direction, they kind of let a little bit of backflow. If blood is cycling back through, your oxygen levels are going to be lower. So tell me what your patient is going to complain about. I am tired. I'm tired. Okay, yes. I don't know, Doc, I'm tired. Stenotic valves, which means that your valves are too stiff. So your heart has to work really hard to force that blood through to its destination. Tell me how your patient's going to feel. I'm going to be tired. But a sign that you have stenotic valves and have had it for a long time, not only are you going to be tired, but your heart's going to be a little bit bigger. Because your body, if you use a muscle a lot, it starts to get bigger. So we're going to see kind of an enlarged type heart setting. And an enlarged heart actually means a weaker blood pressure. So we start to see problems over time as a result of that. So bad situation in both cases. Patient comes in, I'm tired, and I don't know what's going on. How do you fix this? You replace the valve. You either give them a synthetic one or you give them a valve from a cadaver, so somebody who's died. And they've also done pig valve transplants using pig hearts, using those valves. Pulmonary circulation. Here it is in words from beginning to end, so get ready. So it enters the right atria. The right atria receives blood from 3 places: superior vena cava, inferior vena cava, and coronary sinus. That goes into the right atria. From the right atria, it goes through the right AV valve or tricuspid to the right ventricle. From the right ventricle, it goes through the pulmonary semilunar valve to the pulmonary trunk, which is the pulmonary arteries. We'll take it to the lungs on both sides. Take it to the lungs to get oxygenated. That oxygenated blood will come back through the pulmonary veins, which will be oxygen rich, and the pulmonary veins will dump them into the left atria. The left atria will send it through the left AV, mitral, or bicuspid to the left ventricle. The left ventricle will send it through the aortic semilunar valve, through the aorta to the rest of the body, and then it will cycle back up through the superior, inferior vena cava, or coronary sinus. Okay? And I did like 2 or 3 slides here, yeah. And everything that I just said is here in writing, in that order. Here is showing you a diagram of the movement of blood and showing you going through the valves and all of that, okay? remember that artery and vein just tell you the direction it's going in reference to the heart. An artery is going away from the heart, a vein is going towards the heart. Red or blue tells you it's either oxygenated or deoxygenated blood. Okay? As far as the pathway through the heart, you should know how the blood flows. You should know that the reason why the right ventricle is smaller muscular-wise in comparison to the left is because the right just has to go a short distance. It's a very localized pump versus the systemic, which is much further. It has to be much stronger. Here's a quick cut. If you can notice this next week when you do your heart dissection, that would be awesome. But the right, they actually hold the exact same amount of blood. They have to because you can't have unequal amounts of blood. But it's how it's spread out. So the right ventricle, the muscle, is much smaller in comparison to the left ventricle. I mean, and it mentions it should be around 3 to 4 times thicker, the left, in comparison to the right. So, good cut there. Coronary circulation. So, your heart pumps blood, but the blood your heart pumps doesn't serve your heart. So, it gives oxygen and blood to the rest of your body, but it doesn't use it for itself. So we need coronary circulation. These are vessels that specifically serve the heart. Listen to what I'm about to say. Coronary circulation is part of a systemic circuit. So when blood leaves your left ventricle and it goes to your aorta, it'll branch right off the aorta to your heart. So part of the systemic circuit is getting blood to the rest of the tissues. Coronary circulation, comes straight from the aorta. Okay, so this is specifically talking about what gives your heart oxygen. Okay, so your heart is responsible for oxygenating blood for the rest of your body. This is what oxygenates your heart, coronary circulation. Okay, so again, arteries and veins. If it's artery, it's going away. Veins, it's going towards. Arteries, in this case, are going to be carrying oxygen-rich blood. Veins are being carrying oxygen-poor blood. And that is correct. Right. And the mailman doesn't necessarily deliver his own mail. Right? So, the left coronary artery, left is going to serve. I'm going to let you figure that out. Okay, good. All right. Okay, good. And the right coronary artery? Okay, good. But coronary tells me that it's serving the heart. Whenever we talk about bypass surgeries, or like I'm having a single bypass surgery, or double, or quadruple, there's 4 vessels that serve the heart. So if you have a quadruple bypass surgery, that means that all 4 vessels were blocked. That means that your heart was not getting any oxygen, or very low levels of oxygen, which means that you're pretty close to doing what? Dying, for sure. When you do have a bypass surgery, we can always tell on an individual who has expired if they've had previous heart surgeries, specifically bypass, because it looks like they have spaghetti on their heart. Because we will take vessels from your legs or other places, and wherever the occlusion is, the blockage, we will cut at the bottom of the blockage and we'll cut at the top of the blockage, and we'll use that extra collateral vessel. We'll create a loop. We'll bypass the blockage. That's what a bypass surgery does. You have 4 vessels that serve the heart. So if you have a single bypass, double, triple,
You don't actually take it out.
you bypass it. You go around it. Mm-hmm. So that's what that's referencing. And when we're talking about the coronary vessels, it's a coronary bypass surgery. So I'm going to make sure that we make that association there. So here you have these vessels. If any of the, like if this one right here was to become occluded, that means blocked. Something is stopping it right here. We would clip it here, and then we would put that collateral vessel and kind of just loop around there. Okay, and of course I made it look like I was drawing and coloring, but it's a really intricate procedure. Like it takes a long time. It's not just like, and it's done. It's a big deal. Also, we're going to talk about these structures here when we come back next week. They're called anastomoses, and we'll talk about the prevalence and the reasoning for those. That was the coronary arteries right there, and this is oxygen rich. Here are coronary veins. This will be oxygen poor. The other 2 vessels, so you have 2 coronary arteries, and they branch out. 2 coronary veins, and they branch out. But the big thing I want to point out here is the coronary sinus. The coronary sinus is this right here, and a sinus is just an opening, a collection duct. This is where all the oxygen poor blood gets dumped back into the right atria. The right atria gets blood from 3 places: the superior vena cava, inferior vena cava, and the coronary sinus. So this is it dumping it back from the heart. Okay? What actually serving that heart.
So is that kind of like once the heart uses the oxygen that was there, then it's going to...
Right. So it would just be like it being in our muscle, our toe, or anything like that. Yes, ma'am. And this is a posterior view of the heart. I can tell because of all the vessels that are there. The apex is also kind of swung over here. You can see the sulci. You can also see the coronary sinus right here. Inferior vena cava, superior vena cava, right atria. When you have your heart, I just want you to stick your finger in there, and you can just feel that atria. It's literally just like, oh. I don't know why I need to make that sound effect, but that's what it is right there. Angina, or angina pectoris. Like, and now the reason why I say it angina is because whenever you watch Shark Tales, I don't know if you've ever seen that movie before, but the big Dawn shark is like, "You're hurting my angina." I'm like, oh. So yeah, you read it. I mean, if you hear it, you're like, I don't even know what he's talking about, unless you're smart, and then you're like, okay, that just means that your heart is hurting. A lot of times, when you have that, if it's a regular thing, you probably have a weaker heart. There's a pain associated with it. But sometimes people complain about it. They're just like, oh, I feel like I have a lot of pressure. Could be that they're having a panic attack or they're under a stressful situation. It doesn't necessarily mean that their heart is weaker as a result of that. A myocardial infarction is a fancy way of saying you're having a heart attack. That's all that is. The degree and the implications of that heart attack really just depend on what part of the heart is being impacted. You have 4 vessels. We just talked about that, 4 coronary vessels. Whenever they talk about the widowmaker, that's the one that serves the left ventricle. And if I cut off that one, and I cut off oxygen to that, there's no blood that circulates to the rest of my body. So that's why it's called the widowmaker, because if you have a heart attack and it's because of that vessel, you're not coming back. Okay? And if you do, that's awesome. Anyways, a lot of people will have multiple heart attacks before they actually have one that's debilitating to them. And that's actually pretty common. When you have a heart attack, some people tend to have a higher pain tolerance, or they don't like to admit that something's not feeling right. So if they're experiencing a whole bunch of pain, they just go sit down, lay down, take a nap, try to just hang out, and they're actually having a very mild heart attack. And they'll do this a couple times. Then they'll have a really big one that they'll fall out and they'll have to go to the hospital. We know you have smaller heart attacks when we can look at your heart tissue and we can see scars. Because every time you have a heart attack, there's a scar left behind. So when we can see those little scars, we're like, okay, look, you've had like 4 heart attacks already. And people are like, oh my gosh, I didn't know that's what was happening. It hurt. But smaller heart attacks, and if you have those and it's kind of a recurrent thing, it leads to a larger, bigger problem, especially if you don't try to correct the issue that you had initially. When you look at a cardiac tissue, so we're looking at a cardiomyocyte, a small little cardiac cell. It has a whole lot of mitochondria, and that's because that's a muscle, and it's constantly contracting. So your heart never stops contracting, hopefully. It continues to do that, and that's why you're still alive today. We also talk about the fact that they have intercalated discs, and they're uninucleated and striated, so that takes us back into O1. So this is what it would look like underneath a microscope slide, or that is a microscope slide. You can see the intercalated disc, the nuclei. They have gap junctions and desmosomes. Gap junctions allow for the flow of ions between the cells, and desmosomes hold that tissue together. Intercalated discs are what have the gap junctions and desmosomes. So that's what is referenced here. And it allows for things to move throughout your cardiomyocytes. This is taking us back to O1 as well, the anatomy, so I'm not going to go back through that. It talks about depolarization, repolarization, hyperpolarization. These were our muscle contractions. We saw that, and I'm going to show you a myogram here because we're going to look at ECGs and EKGs. But cardiac muscle has a whole lot of mitochondria because you need a whole lot of ATP. In the event that you run out of oxygen, does your heart stop beating? No. Your body will take things and start rolling it anaerobically. You'll be tired, but it'll do it. in order to keep your heart going. Same thing it does for your brain. We talked about the glucose and all of that. Anytime you have an ischemic condition, ischemic means that it's not getting any oxygen, so it's anaerobic conditions. It's still going to make ATP, but it's going to leave lactic acid behind, which means that there's going to be soreness and perhaps potential issues in the future. If you continue to have this, it will cause fatal arrhythmias. So an arrhythmia is just an irregular heartbeat. You can have that for a number of reasons, but if it's fatal, of course, that's going to lead to death. Depolarization, remember that's contraction. Repolarization is relaxation. And your heart doesn't have to be told to beat. It has its own little electrical system. Okay, it's the autonomic nervous system when we discussed that. And we're going to discuss it a little bit, but we've discussed that previously. You have pacemaker cells that kind of keep you close to threshold. Once you hit threshold, it depolarizes, and then it goes right back to repolarizing. So, of course, the ion that initiates all of this is calcium. Surprise, surprise. Okay? This is kind of what it looks like here. So I'm here, I hit the threshold, depolarize, repolarize. I'm getting closer, up, threshold, and it continues to do this. This pacemaker potential is what keeps you close to threshold and makes sure that you continue to generate action potentials so that your heart will continue to beat.
You ever hyperpolarize?
Okay. The answer is it potentially, some cells can hyperpolarize to the point where you don't contract anymore. But drugs could, something could slow your heart down, like if you were having a surgery or something like that, you would want something like that to occur. This is giving you a breakdown of the electrical system that serves your heart. Okay, it starts with the sinoatrial node, then atrioventricular bundle, then the bundle branches, and then the endocardial network. I'm going to show you what this looks like. This will start your heartbeat, and then it communicates here. Then this transmits that action potential here, and breaks into your right and left bundle branches. And then here you have the subendocardial. So as electricity is going on in your heart, you can see that it's not innervated any other way. We can speed it up and slow it down, but this is how it's run. When you hear people talk about, I have a right bundle branch blockage or a left bundle, that's talking about the side of the heart in which these branches are occluded or something is an issue there. Okay, so it's impacting the electricity on that side of the heart, which causes a weaker heartbeat. The sinoatrial node is also called the pacemaker. It sets the pace for your heartbeat. Okay, and it generates that around 75 times a minute, 100 times a minute. If something is trying to kind of get you going, it can also be much faster depending on if you're running, exercising, or anything like that. But it goes from the sinoatrial node to the atrioventricular node. From the atrioventricular node, there's a short delay, but then it naturally goes around 50 to 60 times a minute. In the event your sinoatrial node fails, I'm going to go back real quick. If this fails, this will take over. You'll have a weaker heart rate, but it'll still keep you alive. Okay? If this fails, we have an issue. So when it's talking about sinoatrial node and then atrioventricular node, that's what it's referencing there. The atrioventricular bundles, these are going to the right and left, so they're just spreading that electricity to both sides of the heart. Then you have your bundle branches. The right bundle branch serves the right side of the heart, and I'm pointing to the right, using my right hand. So the right serves the right side of the heart, the left serves the left side of the heart. I feel like that's obvious, and of course if it's your patient, it's cross. The subendocardial, this is getting into the tissue of your heart and getting everything else to contract, and then it'll start it all over again. When the atria contract, the ventricle should be relaxing. When the ventricle contract, the atria should be relaxing. So they should be going back and forth, and that's the way that it should spread. This is showing you the depolarization of each part of that heart, not part of the heart, but as it's moving through for a contraction and a relaxation. Arrhythmias are any type of irregular heartbeat, so it can be used for a lot of things. Just when you get scared, that's an arrhythmia. So when somebody says, "Oh, I have an arrhythmia," I'm like, "Oh, like what type of arrhythmia? Give me some more details." Fibrillation talks about the fact that your heart is contracting in such a way that it's not actually sufficiently supplying blood to the rest of your tissues, so it could lead to death. So a defibrillator will stop that random contractions. This is usually fatal if not taken care of pretty quickly. Ectopic focus, so a sinoatrial node, the SA node, the one at the very top, sets the pace of your heart rate. And that's what it's talking about there. Extrasystole. We're going to learn systole is contraction, diastole is relaxation, so systolic and diastolic pressures. And we'll go into that again next week. But extrasystole means that you're contracting more than you need to. The problem with contracting more than you need to is that you're carrying less oxygen and your patient's going to say, hey, I'm tired. Okay? But we see this happening with somebody who takes a whole lot of caffeine all in at once, and they'll have a crash. Okay? Any type of stimulant like that could lead to that extrasystole. If you have a defective AV valve, AV node, not valve, node, which is the second stop, this can lead to a heart block. If there's a heart block, that means electricity is not getting to your heart. That can be fatal. So we have an issue there. We need to put a pacemaker. So these are why those pacemakers get put there. So it's constantly stimulating the heart to generate the electricity necessary to keep you alive. The autonomic nervous system, so this is parasympathetic and sympathetic. If the sympathetic nervous system does something, what is that going to cause your heart to do? Speed up. Heart rate increase, oxygen rate increase. We're going to see all that. Parasympathetically dominant, what are we going to see your heart doing? Just relaxing, slowing, so you can rest and digest. You have your cardioacceleratory, so what is that telling your heart to do? And then inhibitory, to slow down. So just use your common sense there. And that's showing the reading there. ECG or EKG, both the exact same thing, so electrocardiograms. This is reading the electricity of your heart. I'm going to go to the diagram here. In this slides, this one and the next few slides, it defines what each of these is. But what we should see here, and then it should do the same thing over and over again. So you see it coming up a little bit, our P wave, and then you see a complete depolarized, repolarized, back. And do you see what I'm talking about? Like we should see that flow. And it will define each one and what each segment tells us and what's going on in each as you go through these. And I know I'm kind of running out of time, which is why I'm referencing that. This is my favorite teaching diagram for this. So that P wave, it's telling you what's occurring. For right here in this small little gap here, and you can see what's been affected as it's color-coded. Here, this is relaxing and this is being contracted or depolarized and repolarized, and you can see how it's spreading and it's showing the color code there. This is a great reference for showing you what's going on as part of those heart waves. And this is what I'm looking for. This is the type of heart wave I want to see. Okay, so you can see that up there at the top. Here, we can tell something's going wrong. I don't have my normal P wave at the front. That's probably telling me a sinoatrial issue, so we'll look into that. And here you can see that they're not nearly as prevalent and articulated there. So that tells me there's something wrong there. This person's probably weak and tired. This person's probably very, very tired. And this person's probably dead, okay, before they're on their way to die. Because there's no type of rhythm that's that fibrillation. So they're just, and then you need to defibrillate or they're going to die. So this again gives you each of those explaining what's happening during each of those different areas, the intervals. When your heart beats, you should have two sounds: lub-dub, 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 lub-dub. So it's the lub and then the dub. The lub is the atrioventricular valves. The dub is the semilunar valves. So that's those valves are what's actually causing that sound. Heart murmurs or abnormal heart sounds, that's usually because you have incompetent or stenotic valves. So your valves are either too weak or too strong. That causes those other sounds. When a doctor moves that stethoscope in 4 places on your chest, they're listening for each of those valves. And then they'll put it on your back too and listen for each of the valves. So trying to figure out if the blood is flowing the way it's supposed to. If they hear a swirling sound, we know something's wrong. So they're listening for sounds that indicate something's not working correctly. Systole is a contraction, diastole is a relaxation. So systolic over diastolic. Systole, diastole for your cardiac cycle. Okay? This right here is going to walk you through what needs to take place as blood is flowing through the heart. So when a ventricle is filling, for the ventricles to fill, the atria have to be contracting. Does that make sense? So there's a systole here, diastole here, relaxation. When the ventricles are full, the valves are going to close, so the atria are going to kind of swell up a little bit. The ventricles are going to be in systole or contracting, while the atria are in diastole, relaxing. So you're going to see this pattern. It's going to put a whole bunch of words to that, but ultimately that's what's happening. When this is systolic, this is diastolic. When this is systolic, this is diastolic. So we're just using contract and relax. Instead, we're using systolic and diastolic. You have to be able to do that. When you read somebody's blood pressure, the systolic number is the one on top. Diastolic number is the one on bottom. The pressure when they're contracted is the number on top. When they're relaxed is the number on bottom. The lower, the better, unless they're in sickness. Anyways, EDV is in diastolic volume, so how much blood you have in the ventricles after diastole. So when it's full, how much blood do I have there? Ventricular systole. Systole tells me it's contracting, so right now the ventricles are about to do this number. Okay? At the end, we can calculate the end systolic volume. There's always going to be a little bit of blood left over. The least, the better. The less, the better. I don't know what I'm trying to say. I don't want a lot of blood left over. That's what I'm trying to say. Whatever word needs to go there. Isovolumetric relaxation. So we're not anything, the volume is the same. ISO tells you it's the same volumetric, same volume. Okay, this causes a dichrotic notch. Where is that? So we're going to see a brief rise in aortic pressure, which allows for the propelling of that blood. So it causes it to kind of shoot it off, which is how your blood makes it through your aorta so quickly, and there's a stretching mechanism there for that. Another great teaching diagram. So you can see where everything's moving based on its color. You can see the atrioventricular valves versus the semilunar valves. Open, these are closed. When these are closed, these are open. And so on. You can also see where everything is pressure-wise. Okay, so it puts everything together, the blood flow through the heart. Diastole is relaxation, systole is contraction. Cardiac output is your heart rate times your stroke volume. Heart rate, everybody gets heart rate, but stroke volume is how much blood is pumped in 1 minute. So stroke volume. Okay? I said 1 minute. It's one beat. It can't be 1 minute. It's measured per minute, but it's one beat, sorry. I just misspoke. So at rest, we would expect around 5.25 liters per minute. For people who are out of shape, it's going to be rough whenever they do start to pump more blood. If you are in really good shape, it's not, so your heart doesn't struggle as you're starting to circulate more blood for whatever reason. Okay? So it mentions 4 to 5 times for people who are non-athletic, and those who are athletic, you can pump a whole lot more blood. Your stroke volume is calculated by your diastolic volume. So after it's full, subtracting what's left when it's at rest. So that's how much blood you're actually moving. Your end diastolic is when the ventricles are filled. Systolic is when they're forced shut, so they've released. Whatever the difference is how much you're actually circulating. That's your stroke volume. And that's per beat, not per minute, like I misspoke a moment ago, just making sure that I correct again. Here, for the next few slides, it says, under sympathetic activation, your heart begins to speed up. Under parasympathetic, what happens? You slow down, okay, but does it ever stop? No. So it mentions that, and it continues to discuss sympathetic versus parasympathetic. And here you have somebody working out, and they're sympathetic, what's going on that wise. So you can see the flow chart. Hormones. Epinephrine is going to cause your heart to do what? Speed up. So it's going to discuss that there. Hypocalcemia, hypercalcemia. We've discussed this in a previous chapter, but hypo tells us it's low, hyper tells us it's high. If I have low amounts of calcium, how's my heartbeat going to be? It's going to be weak. If I have too much calcium, it's either going to be too strong or going to tetany. What's tetany again? Complete contraction, which leads me to, okay? Kalemia is referencing the potassium, okay? So hyperkalemia, when you have, and potassium is what's flowing out during the muscle contraction. Hyper, it's too much. Hypo, it's not enough. Either way, they're both homeostatic imbalances. What happens to your heart rate, or how else is your heart rate affected? The younger you are, the faster your heart rate. Females have a higher heart rate than males, generally speaking. In utero, a heart rate for a fetus could be up to like 140, 150 beats per minute, and it begins to decrease with age. If you're exercising, we expect your heart rate to increase. If your body temperature is increasing, you're getting hotter, your heart rate will also increase. Tachycardic means you have a high heart rate. Bradycardic means that it's low. So those are used in terminology as reference points. Congestive heart failure is where your cardiac output is consistently low. So you're not generating a whole lot of blood, your oxygen levels are low. This leads to enlarged hearts, weak vessels, eventually a heart attack. So it's over time. It could be a lot of different things. Pulmonary congestion, this means that your blood is backing up into your lungs. This means that the left side of your heart is failing, so blood is stuck in your lungs. If you have peripheral congestion, that means that the right side of your heart is failing, and so blood is pulling in your organs. We see a lot of swelling. Ultimately, your patient comes in and says, I'm tired. I don't know what's going on. Ultimately, you can still live. If one side is weaker, the other one is going to be impacted, of course, and hopefully you fix it, or later on in life you will expire. Here's your embryonic heart, and here's your heart at birth-ish. You can see that hole there. We talked about the openings in between the two. The two that you need to be familiar with are foramen ovial, which becomes the fossa ovialis, which is what you and I have now. And the ductus arteriosus is where in between the pulmonary trunk and the aorta. So this is between the two atria. This is between the pulmonary trunk and aorta. Let me show you what I'm looking at here. Whenever you have a baby that's born with the septal defect, they have that hole still open here. If they have a narrowed aorta, this decreases the blood flow. It's there, but it's not as flexible as it's supposed to be, so this is an issue, so that baby's going to have surgery. This baby's obviously going to have surgery. If you have a baby that's born with a lot of heart conditions, there's 4, we call it a tetralogy. They have a hole here, they have that hole there. This is narrow, and the aorta is narrow. Ultimately, this baby is super tired. They're going to be in ICU, but this is less likely than the other two. A lot of babies are born with heart defects. Look at this, as far as the statistics are concerned. As you get older, we start to see a buildup of fats and cholesterols in your vessels. So that's not uncommon. Atherosclerosis. We don't want that to happen, but take care of yourself and it won't. And that's it. All right. Good day. I will see you.